to opioids. We're going to learn about them. Obviously, they're prescription medications. And it used to be pain was subjective. So if you went to the doctor, Emily, and you said, I got in a car accident and I can't walk, you know what the doctor did? We're talking 20-ish years ago. Here's a prescription for hydrocodone. Well, you took it and it helped your pain. You took it and it helped your pain. And you were like, this is a pretty great drug. Because my elbow has been hurting for 100 years. It doesn't hurt anymore either. And so you're like, oh, this is great, this is great, this is great. Then you ran out of your script. But then what? But then you went over here and said, oh, my elbow really hurts. And got a script from this guy. And then, because these are made to be taken, generally speaking, we'll talk about chronic pain patients later, but they're generally used to be taken on the short term. So, oh, Miss Walker, my elbow really hurts. Okay, treating your pain. I'm doing my job as a physician. This is 20 years ago, it's not the CV now. Doing my job as a physician, get your medication. The prescription's gone. Oh, I think I have an abscess tooth, Mr. Baker. So at that point, 1, 2, 3 scripts has led to a psychological dependence. Then you buy it on the street because nobody will write the script. And it's a whole vicious circle like this. Now, the flip side of that is true. You have chronic pain and you have been taking this medication for 20 years. And you function well because you need it. You truly need it because you have whatever you have. You have vertebrae degeneration and whatever else you have. And you've been taking it, you've been taking it, you've been taking it. Rightfully so. You needed it. You were taking it for your prescription. And then suddenly all these laws went into place and said, oh no, we don't write opioids anymore. Well, what's happening to you now? You're going through withdrawals for a medication that you needed and you're now having to go to pain management, jump through hoops to get your medication that you rightfully need. So it's a very delicate balance of these medications. Has a whole lot to do. There's so many laws in place now that an ER doc can barely even write a script for Norco without, you know, like a visible shattered something, you know, and education in regards to prescribing these opioids. So all of that to say, they are not, and we're going to learn about their mechanism of action. They are not addictive in and of themselves. But when you start to take them and you're not, those receptors, those pain receptors are not there, and then you start taking them, but it's not to trigger the pain receptors, that's where dependence kind of takes place. And we're going to learn about that in a little bit. Okay, so important things that you're for sure going to have to know from this chapter, wrong chapter. Important things you're going to have to know. Go to chapter 15. You're going to need to know the brand names for these opioid medications, because people don't usually say, I take, so they'll tell you what they take, but they'll say, oh, I take Roxy's. That's what they'll call them. I take Roxy's. Well, Roxy is the name for Roxyset. That's the brand name of oxycodone 5 milligrams. So it's important that you know what these medications are. Percocet, one that is not listed on here is Loratab. Loratab has hydrocodone in it. Hydrocodone and oxycodone are not the same drug. They are both opioids, but they cannot be used interchangeably. They're not the same drug. So I need you to know that there's a difference between hydrocodone and oxycodone. And so I may have to attach it. If somebody finds it before I do, I want y'all to know, oh, here it is. I really need y'all to have a very big understanding, and we'll discuss it in a bit. On page 180, I need you to know the difference between tolerance and dependence. And we will talk about that in a minute, but that's a very, very important concept that we're gonna have to take away from here. Okay, so let's talk about opioids. The World Health Organization developed a 3-step analgesic protocol based on intensity as a guideline for treating pain. This pain ladder directs the use of both opioids and non-opioids in the treatment of severe pain. So, remember I told you 20 years ago, you broke something, you went to the ER, and you could get your pain medication as you needed it, and now that's not the case. It's because the World Health Organization recognized this pandemic, this opioid crisis that we have going on, and they said, what steps can we take to protect, the world from this pandemic? So, or it might be epidemic, it's not a pandemic, epidemic. So that ladder can be found on, thank you, John Essence is on it today. So, if you come in, somebody be my patient, and I'm gonna just kind of demonstrate how this works. Yeah, okay, nobody's like, all right, whatever, okay, so I've got off the trampoline, or not trampoline, I ain't trying to jump on the trampoline, let's be, I was chasing my kid, trying to give her a whooping. I'm just joking. I was running, doing my little couch to 5K, and I rolled my ankle, and I just cannot put any weight on it. That's you're my patient, okay? So that's what's going on with you. And so what are you coming to the ER for today, Miss Emily?
Rolled my ankle.
Okay.
I'm in pain.
You're in pain, okay. So what, is it persistent, or is it getting worse? It's getting worse. Okay. So first thing we'll do is some diagnostic stuff. We're gonna do a little X-ray, whatever. So the step 1 of this ladder is to start with a non-opioid plus an adjuvant. So what do y'all think would be first option for her as a patient? Treatment. If we're prescribing her medications, what do y'all think? An anti-inflammatory. So maybe what drug class? An NSAID. And what is adjunct therapy? What is something else we could do in addition to that? Distraction. What's something a little more physical? But that is rapid. 1 other thing. Ice it. Ice, elevate, NSAID. Now, are we completely disregarding your pain? No, but we are starting with the least invasive methods first. Instead of saying, oh gosh, it's so swollen, it looks so bad, here's some Lortab. Because when we say, here's some hydrocodone, where do we have to go up from there? A little bit of morphine. Then a little bit of Dilaudid, maybe some fentanyl, but she rolled her ankle. She's not in excruciating pain. So what happens if she gets in a car? So for the people who have been given these higher treatments, higher up on the ladder, if you come in with a car accident and you're already accustomed to taking these drugs, where do we even begin? So that is the rationale. The rationale is not to say we're disregarding your pain altogether. The rationale is to say if ice and A-strap and 800 milligrams of ibuprofen 3 times a day works for your pain, why do we want to give you something like an opioid? Does that make sense to y'all? That's first treatment. Second treatment would be opioid for mild to moderate pain. So we might say take ibuprofen every 8 hours times, schedule. And then we might say take this hydrocodone, but use it sparingly. Once a day for severe pain. Does that make sense? And then as we move up the ladder, it will be all of those, and we build upon it. So the idea is least, restrictive is not the right word, but like when you think about restraints, you're not gonna tie somebody to the bed if you can have somebody sit next to them at the bedside and watch them. It's the same idea. We can treat our pain with aspirin, NSAIDs, and Tylenol, then we're not gonna run to these higher medications. All right, so opioids are controlled substances, okay? They're on that, the little list that I showed you guys at the beginning of the year. Who determines if something is a controlled substance? Do y'all remember that? Two agencies.
The DEA.
DEA, you are, oh, she is on it today. She's like, I studied last night. The DEA and who else? FDA, great job, y'all. So, the issue with, and it's not an issue, opioids are a very good thing. I don't want y'all to think that I have like this avergence to opioids. They're just overused in our nation. When you need them, they're a beautiful thing, and I'll tell you a story about that in a little bit. Okay, and I mean, that was my whole job, was to give opioids, because all my patients were end of life. And so that's the other reason that this is sad, and the reason I know the pandemic is so bad. There's so many times that we gave them these opioids, and they were supposed to put them in their refrigerator for emergency uses, and their daughter or son used them and filled them with Kool-Aid. So when my patient was in a pain crisis, couldn't give them the medications that they needed because their family sold them. We would have to bring lock boxes to the houses, you know, and watch people suffer because this pandemic, you know, because this, it's not a pandemic, epidemic is so bad. So the mechanism of action for opioids, which is the same reason that they can cause dependence, the mechanism of action does not affect the tissues. So when we talked about NSAIDs, they affect the tissues in that they are anti-inflammatory, or they affect the prostaglandin synthesis or whatever. Opioids change the patient's perception of pain, which means they work where? In the brain. Okay, they're not fixing the problem. They're making the patient feel better, which at the end of the day is the goal. But it comes along with some other things. So they treat pain centrally in the brain. Opioid analgesics, if you open your book to the med list, okay, they can be opioid agonist, which means that they bind to those, they block. Okay, so an agonist, this is where I said I would make y'all have a better understanding of what an agonist is. Okay, so you need to find something to put something in. Okay, this is a pain receptor. Okay, if this is our pain receptor, I'll make it right here for some of people that are watching. Okay, if this is a pain receptor, an agonist essentially is going to go in here and it's going to bind. So that pain signal, blocking the pain signal, because that agonist, that medication agonist, has already taken up that place. Does that make sense? So, an agonist is going to bind to the receptor. The result of that binding to the receptor is the fact that the original substance or the original impulse can no longer reach that receptor in the way that it should. Does that make sense? So if something is a partial agonist, it binds but lets a little bit through. Does that make sense? Okay.
So kind of like it activates the receptor to feel something else instead of the pain.
Yes, essentially yes. Then if it's an antagonist, it completely gets rid of, okay, so we'll talk about antagonists in a second. Okay, so your agonist, they activate receptors and they cause that action. Does that make sense? Agonists activate the receptors. By activating those receptors, they cause the pain relief. You can't have both. You can't have a pain receptor. I mean, you can't have a pain response. I guess technically you could, but ideally you can't have that same pain response, and you can't have that medication bind at the same time. So if the medication binds as an agonist, then it activates those receptors and causes action. Those are things like all the medications that we talked about: hydrocodone, Demerol, morphine, oxycodone, oxymorphone. All of those medications are your agonists. They're opioid agonists. Okay? Opioid agonists and antagonists are going to be things that activate or block the receptors, causing effect to a lesser extent. So that was that half and half thing that I showed you, right? So they are blocking half. These medications, you're going to hear people say, I take Suboxone. And there's a big thing that's like, well, what is Suboxone? Is it an opioid? Is it not an opioid? It is an opioid, and people are often put on it to wean them off of opioid addictions. Even though that doesn't make sense, it's an opioid, but to a lesser extent. Does that make sense? It's to a lesser extent, and it allows some of those receptors to come through. So, I'm way off on this. So they can be, so opioids in general, they can be opiates, which come from nature. They can, morphine, heroin, all of those things, and then they can be synthetic. So they can either be made, is something, that's how we knew that this works, because opium comes from nature, and then synthetic opioids are going to be your things that are made in the lab, like your medications. Okay, so they act by working on the cells within the central nervous system. They are agonist agents. They are analgesics. Say they can be analgesics. They can be partial agonists, agonist antagonists, and they can have non-intended responses. So when I am making these charts for you guys, I will very, very, very clearly point out these are agonists, these are antagonists, these are partial agonists. And you've got to know that. Because what would we, I'm getting ahead of myself. Just hold that thought. This is going to make sense whenever I break it down on your little breakdown chart. So they're used to treat pain. They can also be used to manage opiate dependence. Remember, what kind of medication is going to manage opiate dependence? A partial agonist. Partial agonist. They are used in adjunct with anesthesia. We will often give pre-surgery. We gave everyone, not everyone, but most people who are having a big surgery, we gave them Versed and fentanyl. Now, does that mean that, I don't want y'all to think one dose of fentanyl does not cause psychological dependence. Taking fentanyl with surgery is a supportive adjunct, and your body is fixing to be in pain, and it is a prophylactic. It's good for your body. It's very good for your body because then your heart rate doesn't reach 200 during surgery. You're relaxed. You don't wake up in a great deal of pain. So very, very good uses for that. They're a beautiful thing when you can get them, like I've seen pain patients who didn't want to take oral medication anymore, A, because they couldn't get it, or B, because it just wasn't effective anymore, and they would get little pain pumps in their back, little intrathecal pumps, and they're implanted right here in the abdomen, and there's a little bitty small tube that goes underneath the skin, and it releases into the intrathecal space, and it gives just a minute amount of morphine on a continuous basis directly, to where those issues are. Go from having absolutely no quality of life whatsoever to like picking up their grandkids and enjoying life again. So that is what intrathecally means. And then they can be used to treat severe diarrhea, intestinal cramping. That is, just drew a blank of the medication. I want to say Lamodal, but that's, yeah, Lamodal. Lamodal with atropine. And then for persistent cough, does anybody remember the cough medication? It's an antitussive, but it's an opioid antitussive. Yay, good job, good job. All right. So the biggest thing, the two biggest always things you need to remember about opioids are they cause respiratory depression and CNS depression. So if they cause CNS depression, what is our priority? Yes, ma'am, it is. It's safety. These are the medications we're not driving heavy machinery. We're letting our jobs know if we were prescribed these medications. And respiratory, what is our normal respiratory rate? 12 to 20. Are we giving opioids to a patient whose respiratory rate is 11? No, why?
It's already depressed.
It's already a little bit depressed. It's going to be depressed more. The other, these are in the order, well, I say they're in the order. Respiratory is first, CNS is second, GI is number 3. They cause severe constipation. Severe constipation. What is a medication that we might start? Is this kind of feel like it's coming together, all of pharmacology? What is a medication that we might start patients on, post-surgical patients who are given hydrocodone or some sort of opioid? What is a medication we may start them on? Stool softeners. Yes. What is an example of a stool softener? Starts with a D. Yes, it does. DocuSafe. Okay. So they can cause urinary retention. They can cause pruritus, rash, and urticaria, and they can cause sweating, pain at the injection site, and local tissue irritation when given IV. We don't give them to people with acute hypersensitivity, or not acute, with hypersensitivity to the drugs. We do not give them to people with acute bronchial asthma, emphysema, or upper airway obstruction. Why not?
That's all respiratory.
That is all respiratory issues. Now, again, y'all know risk benefit. If your patient has all of his extremities crushed in a motor vehicle accident, but he has a history of emphysema, are we not going to treat his pain? No. We're going to still treat his pain, but what are we going to make sure the heck we're also doing? More than ever before. Monitoring his respiratory status. All right, we're using them very cautiously in older people. Patients who are considered opioid naive. We're using them cautiously in people who have never taken opioids before. Well, the biggest reason, if you've never taken opioids at any point in your life, and this is a general statement, but you've never ever taken an opioid versus you have, who is going to be more sensitive to the drug? The one who has never taken it. They are considered opioid naive. Not because they don't have knowledge of the medication, but because their body is more sensitive to it. Lactating women, because it passes through the mammary gland, through the milk. So what's going to happen to baby if mama is taking opioids?
Respiratory depression.
Absolutely, 100%. Y'all heard what she said? Okay. Which is why, when y'all will learn in OB, it's not that opioids are never used, but if we can give an epidural that's not going systemically, it's not getting to baby. Does that make sense? Mom, at the end of the day, mom has pain relief, but baby's not getting effects of that. All right, true or false? World Health Organization developed a 2-step analgesic protocol based on intensity as a guideline for treating pain. How many steps is it?
3 steps.
3 steps. I was like, that is true. But I forgot it said 2 steps. 3 steps. Good job. All right, interactions. Opioid analgesics. They interact with alcohol. How come?
Is it seen as depressing?
Yes, ma'am, it is. Antidepressants, sedatives, phenothiazines, all increase that risk for CNS depression, okay? Opioid agonist, antagonist, because those are partial, an agonist, antagonist is a partial agonist. Does that make sense to y'all? I know that's a lot of words. An agonist, antagonist is a partial agonist. So because of that, the people who go from full opioid agonist to that opioid agonist, antagonist have a risk for withdrawal symptoms. Does that make sense to you guys? They're taking a step down. We're gonna watch, I'm gonna show y'all a video, I don't know if it'll be today, but of what opioid, it is like hardcore. When somebody's coming off and they're going through withdrawals, it is really sad. It is, they're very, very ill, truly ill. And then barbiturates, remember I told you, those used to be used for anxiety, they used to be used for seizures, but they have a lot of, their adverse reactions then are the good reactions with barbiturates. But when used in combination with opioids, they cause significant respiratory depression. So, what is it for this chapter? And y'all answered most of my questions along the way. What are we assessing in our patients that we're about to administer opioids to? Their respiratory status. In addition, not just the number, their depth of respiration, all of that. Also, their cognitive status. If they're talking like that, are we a little bit slightly worried to administer these medications to them? Yes. We're assessing their pain. If we're given these medications IV, how would we check back in 30 minutes or less than 30 minutes?
Less than 30
Yes. So document the description of the pain, allergy history. All right, in addition, so respiratory rate is priority. But in addition to that, blood pressure and pulse. All of those vitals are important. Details of pain. This is where you need to use your nursing judgment. If your patient is receiving relief from their medication for the first 2 days of your shift, and on the third day, you go back and reassess their pain, and instead of going from a 7 to a 3, they've stayed at a 7 and they're rolling around in their bed. Is your immediate response, I'm sorry, it's not time for your pain medicine yet? No, it's not time for the pain medication yet, but you really need to reassess because something has changed. Something needs to be reassessed there. All right.
Could that be tolerant?
It could be tolerance or it could be something systemically, there is an additional problem going on. But either way, regardless of the reason, that is something that needs to be communicated. It's not something that we just rock and roll and say, well, it's to be expected. You've been on this medicine for a couple of days. Ideally, the idea is always to wean from IV to PO, to NSAIDs. So in the same way that we go up that ladder in treating pain, we don't just say, well, no, you're good, you're going home, go into the house and take them off of IV Dilaudid. We don't do that. We say, okay, we're going to do a trial. We're going to take you off your IV Dilaudid that you were getting Q2. Now you're going to get, whatever you're getting, Percocet, Q4. Now you're going to get Percocet, and then that's something that they can go home on. But it's the same way. Bowel movements are so important. Ineffective breathing pattern, risk for injury, constipation, and imbalanced nutrition all could be effects of these medications. Opioid, true or false? Opioid is a term used for drugs that change the pain sensation by attaching to receptor sites in the brain, producing an analgesic, sedative, and euphoric effect. Yes, they are. All right, and our expected our expected outcomes are what?
Okay,
Pain. Patient is free of pain. What is another expected outcome?
they can do their ADLs.
They can do their ADLs. What is another expected outcome? I'm thinking gut.
They have a bowel movement.
Patient maintains a bowel movement, at minimum every, 72 hours. They are compliant with their prescribed treatment regimen. Okay, we need to talk about patches. We had one of those, you're gonna have a lot of codes. One of the codes that I remember the most in my career, a relatively young guy, like 45, don't remember why he was in the hospital. He was at post-acute, I was taking care of him. Actually, I had taken care of him the day before, I wasn't his nurse that day. And he just coded. And essentially he was stable. I want to say he was a recent amputee. I don't remember what happened or why he was there. He was there for IV antibiotics. But he had a fentanyl patch on. And we found his fentanyl patch in his mouth. He was chewing it. Why was he chewing it?
For the benefit.
Faster. He had a history of abuse. He was chewing his fentanyl patch for that feeling of euphoria, and it killed him. So, is that common? No. Most people don't say, why don't you take this patch and chew it up? But it's important to know when you make something like that available to a patient, probably didn't disclose his previous history, So all of that is important, but I vividly remember coding him.
So how do you know about abuse like that if they don't tell you?
So your job is to always investigate. Sometimes you don't. Sometimes stuff like that happens. You can, as a nurse, did I tell you the story about my guy that was gonna have surgery? I don't think I told y'all that. At the heart of it is a good nurse-patient relationship. People are a whole lot more likely to be honest with you if they trust you and they feel like you are mutually respectful. If you come in and you have you have this judgy, just, you have that kind of attitude, you don't always have to say things. If you have that roll your eyes, they're just here for pain medication kind of attitude, they're not going to disclose to you. Now, in saying that, you still have to be when you're a nurse, you still have to be street smart. You can't just take everything that everybody says and say, oh, well, that's terrible, because it's not always false. Your job is to gather all of that information. So I had a guy one time. So there's some medications that are contraindicated with anesthesia. There's several of them, and then some of them we don't care. If you smoke marijuana, whatever, doesn't matter, it doesn't affect your anesthesia, who cares? So one of my jobs as the pre-admit nurse is to gather that information, whether it's via phone or face-to-face appointment, get their labs, yada, yada, yada. So the question, the way it read was, do you use any street or illicit drugs? And he was probably a little bit older than you guys, and he needed to have a reconstructive surgery on his arm after a motorcycle accident. So I said, do you use any street drugs, illicit drugs? And he's like, no. Okay, so my first flag was he was hesitant. Did I immediately say, are you sure about that? No, absolutely not. But in my head, I knew. So later on, technically I can answer my question no, because he told me no. Okay, so we're a little bit going on a little bit longer, and I go to draw his labs. He's got track marks on his arm. Okay, another thing, I'm taking people at their word, but I'm also not dumb. I've been in healthcare long enough to know that that is a needle stick right there. So I typed, did I say, what's this? So I go back to my computer, I don't know his name, like, Mr. Jackson, you said you don't use any illicit drugs? Nothing at all, you don't use, not even marijuana? So, oh yeah, I smoke marijuana. So okay, anything else at all? He's like, who you gotta tell? I said, and so before I said anything, I said, I am not here to judge you. The reason I am asking is because there are certain medications, and if you go to sleep with them in your system, and this is not me scaring him, this is the truth. If you go to sleep with these medications in your system, you might not wake up. That's why I'm asking. I'm not calling the cops. I can't call the cops, and I don't even care if you do, but I need to know to take good care of you. And he's like, yes, ma'am. I'm like, okay, what do you use? And heroin. Okay. When is the last time you used? Right before I came in. I'm like, okay. So that changes. We're supposed to have surgery in 48 hours. Do I go to my anesthesiologist and say, oh my God, blah, 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 blah. I go and I say, Dr. Wren, a little guy in my office, he uses heroin. Last date of use was such and such. He needs to have this surgery. You know, yada, 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 yada. What do you want to do? So he comes in there. Is he like, oh my God, I can't believe you're a heroin user? No. He's like, here's the deal. These are your options. You cannot go under general anesthesia. You can A, not use for the next 48 hours. We can postpone surgery, and we can do a tox screen the morning of your surgery. And if it comes, the other option is doing this under local anesthesia. We can numb you up from here down. You can still have your surgery. We can give you light sedation, very light sedation, and we can do this. So in doing that, your boy's alive. He told the truth. You know what I'm saying? It's all about, now some people, they will never tell you, and they would rather, but most people, if they know it's a life or death situation, to let you know these things, and they know they're not going to jail for it, then they'll tell you. I mean, I've had more people tell me than not tell me. Like, and the people that I just went to Dr. Wren and like, I know he uses, 100% sure I know he uses, and he told me no, he said do a tox screen and AMO surgery. So that's another thing, when you have trust between your anesthesiologist, they trust your judgment as well. You know, it's not just about, and it's not just because they have that look. You will learn those CNS depressants, that they're falling asleep during your assessment. They can't keep their eyes open, but they're denying all medications. Well, you're 27 years old and you don't have narcolepsy, and there's a reason, you know, that you don't have, all of these things. So you'll learn the things that go together. But the biggest thing is in knowing that, do you treat them like garbage because they're a drug user? Absolutely not. Do you not treat their pain because they're a drug user? No, your boy still needed surgery. He had a shattered arm, So those are all things that are important to note in regards to all of this stuff.
So what about like if they're like to opioids in specific, if they're addicted to that? Like I feel like they would just never disclose that because they want more. Is it something you can get from like other facilities?
Things in place outside of their honesty, 100%.
Yeah.
Every pharmacist that goes to type in something, if they type in a script for a new opioid, it'll pull up all of those opioid scripts that were administered in this parish within the last 30 days. And I might be like making up numbers, but in that way, and then they say, red flag, red flag, red flag, and these people will come up as a red flag. So everybody does their due diligence. If they get by on the physician, then the pharmacist, and then ideally as a healthcare team, we all work together to ensure that our patients get their medication. And sometimes the flip side is true. I had a hospice patient, and he was, poor darling, he was miserable, like just one of the most miserable people that I've seen. And he was a new admit, and he came onto our services, and they're like, he's been hospice shopping, and I probably shouldn't tell you all this, but he's been hospice shopping, he just wants drugs, yada, 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 yada. We're his fourth hospice. Well, that draws a red flag in general. We're his fourth hospice, yada, yada, yada. And again, just because you have to find a very happy medium of taking people at their word and listening to them and using your brain. You can't just say, oh, yes, here's all the drugs you want. But you also cannot immediately go in with your arms up, and saying absolutely not. So this particular guy, He had transferred from a hospice. He moved in with his daughter. He had transferred from a hospice in Florida. And so we were his fourth hospice. And so when I was doing his initial assessment, he said, I have not had pain relief since I left Florida. I have not had pain relief since I left Florida. Da 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 da. So, so I went to this hospice, they didn't help my pain. This hospice, they didn't help my pain. This hospice, they didn't help my pain. So I'm like, okay. So I called, I got the name, he didn't know it offhand. I got the name of his hospice in Florida. I had his hospice in Florida sending his mom. And the amount of medication that all of these other hospices were putting him on was not a drop in the bucket compared to what he was taking in Florida. Now, were they normal dosages? Heck to the no. They would have killed any one of us on the spot. But he was a lifelong heroin user. So he needed those extreme amounts of medication to even touch his pain. So our hospice doctor was like, it wasn't just his word. We had the records to back it up. And the nurse's notes that said, patient free of pain, blah, 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 blah. He was even in a hospice house over there trying to get his pain under control. Well, when he came onto our services, it was, had we just said he's hospice shopping, that man would have died in excruciating pain because he had a history. That's not fair. You know what I'm saying? That's not fair to die in that kind of way because you have a history. Yeah.
So he builds up your tolerance.
So heroin is basically a street opioid. So for that reason, yes, it builds up your tolerance because it's a street opioid.
So why didn't it kill him? It's like a toxic level to a normal person.
So because he had a tolerance, and all his receptors were shot.
Okay, so it wasn't really absorbing all.
Correct. His body was not utilized in a way. And I'm going to make y'all learn the difference between tolerance and psychological dependence, and all of that stuff. So it goes very, very much both ways. Like, you have to be smart and know that this is a real problem, but you also have to use your nursing judgment and be empathetic and compassionate regardless of your patient's history, okay? I promise not to talk for a long time, but I need to tell y'all about chapter 16 because it's 2 pages, okay? And it doesn't make any sense for me to talk about it tomorrow. All right, well, let me do this. Morphine, so controlled release substances absolutely positively cannot be what? Did I say controlled substances? I'm sorry, controlled release. Controlled release or sustained release, they cannot be crushed or chewed. A lot of your medications, so you will have short-acting opioids and you will have long-acting opioids. Your long-acting opioids will be controlled or extended release, okay? Like, it'll be morphine, sulfate, ER, or, whatever like that. So they cannot be long-acting, extended release, cannot be crushed or chewed. Transdermal, that's why I got off track. My little guy that had his transdermal patches deliver a certain amount of medication over 72 hours, okay? So the majority of chewing them is not normally a thing that happens, okay? The biggest thing that you need to know, you must document the date that it went on, so you know the date that it came off, that it's to come off, and you also must put it on a non-hairy area, and you need to put it on an area, you need to make sure that it's remaining on your patient. It's supposed to be there for 3 days. So if it falls off in 24 hours, they're not getting any of their medication. Those are things that you need to assess as a nurse. And then on the other flip side of this, some people are incredibly terrified to take opioids because of all the stuff that I just told y'all. So people who are in horrible, horrible, horrible pain are like, no, my grandson's addicted. No. But when they're taken for the right reasons and you have those pain receptors, that likelihood of dependence decreases significantly because they're able to target the receptors. Does that make sense? Like, When you don't have pain, they're just targeting random receptors in your brain and you're just getting that euphoric feeling. But when you have pain sensation, then it can specifically target those pain receptors. Provide a good and aggressive bowel program. We are going to encourage the mess out of these patients to take their prophylactic bowel medications. And we're doing that because it's a whole lot easier to prevent problems than it is for your patient to have an impaction and dig it out. It's not comfortable for them. It's not fun for you. It just makes a whole lot more sense to prevent these things. So education is huge. Epidural, when we administer epidurals, it can be given at a lower concentration because it targets specifically. Oxygen resuscitative devices and intubation equipment should be readily available if they're getting high doses of opioids, or if they're getting it specifically in the epidural space, or something like that. Report a significant decrease in the respiratory rate below 10 breaths a minute. Also note those pulse changes and a decrease in blood pressure. There are nursing diagnoses: ineffective breathing, risk for injury, constipation, imbalanced nutrition, because they can cause significant nausea and vomiting as an adverse reaction. And then opioid drug dependence, provide adequate pain relief to prevent returning to addictive behaviors. Okay, so we will talk about treating pain. When they're used to treat opioid dependence, I told y'all the type of medication that they were going to get for that. It is usually like a step process too. So they will go, levomethadil, and then 48 hours after that, they will start on something like methadone, and they will taper down from there, ideally. That's what methadone, have y'all heard of methadone clinics? There's actually clinics that prescribe methadone to heroin and fentanyl addicts in an attempt to, taper them off. That's part of their treatment regimen. Coming off cold turkey is not okay. Education. Let them know it's for pain relief, provide information on the adverse effects. PCA, do y'all know what a PCA is?
Like a pump.
It's a pump, and you press the button,
And it gives you a pain.
and it delivers medication. There's a lockout on there, so educating that only the patient is to push that button. Nobody else can push it for the patient. It is patient-controlled analgesia. So patient can push the button. Patient cannot push it too many times because there is a lockout. You set it in the computer. Excuse me, there it comes. You set it in the computer on the back of the machine. It locks with a key, so it cannot deliver more than, 5 milligrams of morphine per hour. So every, so-and-so minutes, it'll deliver 0.5 milligrams. And the patient can, and the goal with that is to push that button unless they need it. That way we're not just saying, here you go, here's this many milligrams of morphine. It also tells us if they're pushing it like this, what needs to happen to their medication dosage. It needs to go up. Okay, the last thing I need to tell you guys, chapter 16, an opioid antagonist. This is a new group of drugs, and y'all have all heard of this drug. An opioid antagonist reverses the effects of an opioid drug. So essentially, if this is our opioid, we had our agonist, we had our antagonist. Our opioid, we had our agonists, which were all the drugs that we talked about, all of our medications. Then we had our partial agonists, which were the ones that we give for dependence. So these receptors are covered up, right? The receptors are blocked by those opioid receptors. An opioid antagonist completely reverses it. So it is given, what do you think an opioid antagonist is given for?
Like feeling allergic reaction, overdose.
Potentially, but that's not an overdose. If a patient is overdosing, then we're giving an opioid antagonist. What is the opioid antagonist that we give? Narcan, naloxone. It is now available over the counter. That is a new thing because it's one of those things. Now, are people buying it? Not necessarily, because a lot of times the patients who are in need of it, in terms of overdosing, are spending their money on other things, unfortunately. My husband and I have had the conversation. We don't let him come around, but his brother has overdosed multiple times and been brought back multiple times. It's a very, very sad situation. So it becomes this, it's not just a, yes, it's a treatment, but is it enabling also, to have these things available to these people? And that is a big conversation that's going on in our nation. A lot of your EMS people are like, they don't overdose. I mean, not that they're being cold, but they made that choice, which I get. But then you got a lot of mamas who are like, I don't want to find my son in his truck. If I find him in his truck, I want to reverse this. So it is very much a conversation that will be held throughout your lifetime. But the treatment for an opioid overdose is naloxone. Now, if it rips, I mean, this is just a visual for you guys. If it rips all of this out and completely reverses it, what's happening to your patient upon giving this medication? Their pain is back at full force and then some, because you have taken all of that away. Okay, so that's important to know. Now, so an opioid antagonist reverses the effects of an opioid drug. So ideally, their pain may be back, but what happened to their respiratory status? They're alive. It's back up. But this is used when patients experience extreme adverse reactions, such as respiratory depression. Do they have to be dead to give Narcan?
No.
No, or I say dead. Do they have to have a respiration of 2? No. We can give it at a lower, before they completely, if we can't wake them and we can't arouse them, and they just had a knee replacement, we're not waiting to give them Narcan until they're not breathing at all. We're reversing the action of those opioids at a respiratory rate of 8. Does that make sense? At a respiratory rate of 10, we might stimulate, try to wake them up. Respiratory rate of 8, it's not completely 8 and non-responsive. If they're 8 and they're still talking to you, that's a different story too. But if you cannot rouse them and their respiratory rate is 8 and shallow, and we know that they're getting opioids, we're going to use some Narcan. They reverse all of the effects of the opioids. Patients who seldom use opioid pain relievers are termed opioid naive, and they're at greatest risk of experiencing respiratory depression when administered opioids. So is overdose always purposeful?
No.
Absolutely, positively not. We had a lot of codes, I say a lot of codes, we had many codes at Cypress because we did a lot of surgeries. Our surgical patients were receiving opioids because they needed them, but many of them had never used them in their life. So even when given cautiously, and I say codes, a lot of rapid responses, even when used cautiously, that respiratory rate can drop. That's to be expected. And sometimes you don't know that balance until you see how your patient responds. That's why it's incredibly important to not give your patient a medication and not come back for 4 hours. You need to at least lay eyes on your patient, make sure that they're okay. So opioid agonists, we know what they are. Opioid agonist, antagonists, I know y'all don't know the drugs yet, but y'all know what they're used for. And then opioid antagonists, you already know the drug. You know about NSAIDs, you know about the stuff we talked about yesterday. Tomorrow is pretty much going to be a review, because the only chapter that's left is anesthesia drugs, and we don't give a lot of anesthesia drugs. We just need to know how to monitor those patients. Okay? Questions, comments, confusion? Y'all feel like you're going to do good on this test, huh? It's usually my best performance on a test. So that's encouraging. It's my best performance on a test if you think it through, and you write down what you know. But y'all are already out loud telling me what you know, and that makes me feel better. We good?
Yeah.
Peace out.